This is the second of two lectures that will discuss meniscal lesions. Specifically, we will discuss how to evaluate for possible meniscal lesions in the knee. There are two common mechanisms of injury that can occur with a meniscus tear. First is an acute mechanism of injury, which can occur from an axial load on a flexed knee that is rotating. Remember, the meniscus is a secondary restraint against rotation. So any injury involving a rotary component, you should be suspecting possibility of meniscal damage. In addition to rotation, if an individual has an axial load on a flexed knee, as seen in this picture here, there's an opportunity for the meniscus to be torn. Meniscal injuries can occur with or without contact, just like ACL tears can occur with or without contact. As that knee flexes into more hyperflexion, it's going to cause the tibia to get pinched, the meniscus to get pinched between the tibia and femur, as seen in the picture. The other common mechanism is a chronic mechanism that occurs in the older population because, as we indicated, the meniscus is predominantly made up of water, and as we age, it begins to dry out. And as it begins to dry out, what can occur is something called a degenerative tear. So it may take less force or even injury for a chronic meniscal tear to occur. You can get a lot from your history questions, as we've discussed throughout the semester. In addition to the standard questions that you would ask as it pertains to their chief complaint, establishing a mechanism of injury, understanding their symptoms, their ADLs, and previous history, there are specific questions within possible meniscal tears. Specifically, the type of pain would be some type of acute onset, if it's an acute, or possibly chronic, and it's going to be some type of sharp pain. Another key history question that we ask is about a pop or a snap. But in addition to that, we want to add in a couple other features, such as do you feel catching, clicking, or locking? These are going to be key features for how to allow you to consider a meniscal tear if it is discussed in the history. Another meniscal tear possible history question is asking about their range of motion. Specifically, do they feel an inability to straighten out their knee because it's getting locked, so they can't fully straighten their knee? By asking that question and getting that response, you may possibly consider, based on the subjective history alone, a meniscal tear. Giving out. Specific ADL questions include pain with going into like a deep knee bend, or pain going up and down stairs when the knee is in more degrees of flexion. And then also the insidious onset with the older population, meaning unsure or unknown cause of pain. And that would be, the why would be, again, because of degenerative tears of the meniscus just drying out and causing a tear. So specific symptoms that they may talk about are a pop, locking, catching, giving out, a flexion contraction, meaning an inability to maintain full flexion, or extension contraction, inability to extend the knee completely. Pain with deep knee flexion. The other symptom, it's really a sign because it's objective, is capsular effusion. Remember what we said when capsular effusion occurs with an ACL tear. If you remember, ACL tear capsular effusion occurs within the first hours to first 24 hours of the injury. However, meniscal tears take at least 24 to 48 hours to swell up in the capsule. So it's important that if you have an acute knee injury, you don't just cross off a meniscal tear until you've seen the patient at least 24 to 48 hours after the injury, so you can ascertain whether or not that capsule is effused. Another key symptom is joint line tenderness, and we'll talk about this. And then also, there are specific special tests for meniscal pathologies that we'll discuss in this lecture. Observation for meniscus. Again, the way you're going to assess for capsular effusion is the same as how you would assess for capsular effusion if you suspect an ACL or a deep fiber MCL tear. You're going to milk the capsule, You do not have to put a lot of pressure when you milk the capsule. We'll go over this in lab. And you're also going to perform a patellar ballottement test. And again, with the patellar ballottement test, you're feeling for that spongy end feel because there's fluid behind the patella. The patella is floating on the fluid in the capsule. As opposed to someone that does not have capsular swelling, the patella is going to hit right against the condyles of the femur. The key feature of meniscus is the capsular effusion develops within 24 to 48 hours. So, if you have an ACL and meniscus damage, you're going to have that capsular effusion right away. However, if you just have a possible meniscal tear, the capsular effusion may not develop until 24 to 48 hours. So, for example, if an individual comes in for an evaluation after an acute knee injury, you rule out the ACL tear because they're not capsular effused, they have a negative Lockman, a negative anterior drawer, but they do have joint line tenderness. You may want to indicate to the patient there's a possibility that they have torn their meniscus. We're going to wait another 24 to 48 hours and see how they respond with regard to the capsular effusion. If they come back the next day and that capsular is effused, they have joint line tenderness and some other symptoms that we talked about earlier, the clicking, the locking, the getting stuck, and some positive special tests, you can clearly rule in a meniscus tear. As we've said before, evidence-based practice is the move of the future in allied healthcare. It's important that you know, by looking at the evidence here within these two articles, that knee joint line tenderness is 77% accurate in detecting meniscal tears. So it's important for you to understand when you palpate the joint line that you palpate the complete joint line. Most meniscal tears occur at the horns of the joint lines, meaning the most posterior, medial, or lateral portions of the joint line. So when palpating during a physical exam, you need to palpate from the anterior portion of the joint line all the way around the knee until your finger falls off the posterior portion of the joint line. Because most common tears of the meniscus occur at the horns or the backs of the joint lines. There are a variety of special tests that you will learn with regard to meniscal tears. The first is an Apley's test. Apley's test is what we're trying to do is we're just trying to push that tibia onto that femoral condyle. McMurray's test, a positive squat, aka duck walk test. It's important if you have the person get down into a duck walk, the pain has to be when they're in the squat. If the pain is occurring as the individual or the patient is getting up and down into the squat, that's more because of patellofemoral pain. And that makes sense if you think about it. As you're going down in knee flexion and coming up into extension, then the patella is grinding on the femur. So if the pain is from getting up and down in the position, it's more patellofemoral. But if the pain is still there when they're down in the squat and walking, you may consider that positive for a meniscus. The third test is a bounce home test. We'll review each of these tests on the next slide. When considering sensitivity and specificity of these tests, if you look in your McGee textbook, the sensitivity and specificity of these tests is not as high as the Lockman, meaning you cannot rely on just the test alone to rule in the possible diagnosis. However, if you see from your McGee textbook, the sensitivity and specificity of each of the tests goes up drastically when you combine a positive test with joint line tenderness. Again, making sure you understand joint line tenderness is a key feature of a possible meniscal tear. So here are the three tests that we'll go through. The first is Apley's test.
Another test that we can do that's similar to Apley's grinding test. We have our patient roll on their stomach. And now we simply take advantage of gravity by letting the tibia and the weight of the foot press down on the joint line. We'll put our finger over the joint line again, and we do the same thing as the McMurrays. We try to track the meniscus between the tibia and the femur with rotation and twisting to evaluate the lateral meniscus, or medially, we'll put our fingers along the medial joint line and do the same thing in the opposite direction. Again, a click and a pop with associated pain is specific for a meniscus tear.
The next test is McMurray's test.
McMurray's test is a test that puts some compression on the medial and lateral joint lines to test for a meniscal tear. You want to put one finger on the medial joint line, your thumb on the lateral joint line, grasp the bottom of the foot, and then bring the knee completely into flexion, put rotation on the tibia, at the same time place a valgus stress on the knee and extend. Then come back, varus stress, extend. Then I'll do the same maneuver with the opposite rotation on the tibia. And that's McMurray's test. And if someone actually has a meniscal tear with a fragment that's displacing, then you will sometimes feel a click or a pop that often is painful. Sometimes, though, someone can have a meniscal tear where you actually don't get a fragment that displaces and you still get pain on the test, and that's considered a positive test.
So with McMurray's test, again, it's important that you know that pain or clicking when they're in this deep flexion position is positive. However, if they have pain after they get below 90 degrees, it will not be positive for meniscus. Pain below 90 degrees is more than less likely positive for patellofemoral pain. If you think about the anatomy, this makes sense, because after you get below 90 degrees, that tibia is not pushing up against that femur that would cause meniscal damage pain. The last test, which is very rarely used, is called the bounce home test. We are not going to really make you practice this test, but you should be aware of it if you see a physician perform this test.
Meniscus is a cushion that sits between the femoral condyle and the tibial plateau. Probably the most specific or sensitive examination is just to palpate along the medial joint line or along the lateral joint line. And if they have pain, you can be suspicious about a potential meniscus tear.
Again, this physician just makes note how important it is and how specific joint line tenderness may be into helping you determine the evaluation of meniscal pathology. Let's watch the rest of this test.
It's not terribly specific, however, because if they have arthritis, they may also have pain in that area. Another test that is effective in evaluating potential meniscus pathology is called a bounce home test. And what you would do is you just let the knee fall into full extension, and in doing that, the meniscus, which is a semilunar or kind of a half-moon shaped structure, creates a hoop stress, and if you have a radial tear, that can exacerbate their pain.
So those are the three specific special tests for meniscal tears. Not one is better than the other with regard to which one you should utilize. In isolation, they are not great, but taken in combination, they are even better, and also when utilized with the rest of your physical exam, it allows you to make a good diagnosis. Meniscus treatment. First of all, in the acute or subacute stages, you're going to manage the symptoms, which means controlling the swelling with ice, rest. Crutches. Again, the idea of crutches should come into play when the individual cannot bear weight appropriately. If they do not have a normal gait, they should be placed on crutches. If you are suspicious on whether or not there is more damage besides just a meniscal tear, meaning you suspect possible ACL tear as well, you should be conservative and place them on crutches. Last thing you're going to do is ensuring range of motion and proper strengthening exercises, which you will learn in therapeutic exercise course. You will refer them possibly for an MRI to rule in a meniscal tear. If there is a tear, there are two options. These two options are based upon where the tear has occurred. Remember, we talked about there are three areas of meniscus with regard to blood supply: the white-white, the red-white, and the red-red zone. If the tear is in the red-red zone, or possibly the red-white zone, there is good blood supply, meaning if the surgeon can stitch the area, it will heal because blood will allow for healing. So, if there is a tear in a red-red or even possibly a red-white, the physician will opt for meniscal repair. If the tear is in a white-white zone, it most likely will be an excision, which means a meniscectomy. It's important for you to indicate this to your patients that if they're going to have surgery, they may ask, well, how long am I going to be out for? The length of time for return to activity is dependent on the repair. Specifically, a meniscal repair is going to be significantly longer because after the surgery, the physician is going to want them to be on crutches for about 4 to 6 weeks before they start their rehabilitation, because they want no weight bearing on that tibia during that time to allow healing. If they have a simple meniscectomy, which is usually they just go in and clean out the area that where the tear occurs, the individual will be back in about 4 weeks. You may be asking, well, why wouldn't everyone want to have a meniscectomy? Because down the road, as we age, we want our meniscus to be intact. So in the future, it's better, if able to do a meniscal repair, because it cuts down on the damage that can occur to the articular cartilage once the meniscus is gone. Because once our meniscus is gone, i.e. torn in certain areas, we then have our articular cartilage beating on our articular cartilage from our tibia. So the long-term effects of meniscal surgery. As you can see here, arthritis is a long-term effect. All of us will most likely have arthritis. Individuals with meniscal surgeries are more predisposed to getting arthritis sooner. This is a picture of an individual with arthritis in their knee. As we have damage to our meniscus, again, we can then have damage to articular cartilage. If there's damage to articular cartilage, over time, it can lead someone to having a total knee repair. This concludes our lecture. If you have questions, please go to the discussion board.